Cancer UK for supporting this study. So what we were hoping to do was to try and look at vaccine responses in our patients, because obviously this has been, quite a worrisome time for an awful lot of people who've been at home during the pandemic. So the aim of this study was to try and understand, do our patients have adequate immune responses? How long do they last? And are there any predictors that can predict who does and who might not respond to the vaccine? So we've done this, we've set this up as a study that's been done through our PNH research tissue bank. And we were very fortunate in Leeds to have a tissue bank set up before the pandemic. And a lot of our patients had very kindly signed up to be part of this. And what that really meant for us was that we didn't need to go through the whole process of trying to get ethics and get people to sign new consent forms. But for people who'd already agreed to have samples done at the time of their routine diagnostic work or at the time of treatment, it meant that we could also take samples to the University of Leeds to look at things like antibody responses. So it meant that we could set up the study very, very quickly at the beginning of the pandemic. So we've been essentially getting samples in from all around the UK, and we've had a few even flown in from Ireland as well. And this has all come through to the University of Leeds. We've also recruited about 45 healthy volunteers. And that's been people, so victims that I found in the hospital, as well as through the lab as well. And then in addition to that, we've got about 10 years of data in our patients with PNH, looking at their vaccine responses after a different vaccine, the meningitis vaccine. And we've gone through and tried to compare to see if there's any kind of pattern there with people who didn't respond to the meningitis vaccine in the past. So just, I've got, sorry for a scientific slide here, but just I've added a slide here just to show sort of what happens in the immune system after COVID infection. So at the beginning here, you've got the COVID virus getting into the bloodstream, and then this stimulates an immune response, which is a combination of both T cells and B cells. The B cells are the ones that make antibodies, and the T cells are the ones that can directly kill the virus, as well as help to recruit the B cells. And then eventually you get memory cells, both memory and T and B cells. And then the final graph here just shows how quickly, so as soon as you've got the infection, you very quickly start to mount an immune response with antibodies. And this just happens within days to weeks. And then gradually those decrease over time, and you start to get your memory T and B cells coming in. And it's a very similar pattern that's seen after vaccination, and we're basically trying to simulate that normal immune response with a vaccine. So the two sort of main vaccines that people have had are either an mRNA vaccine or a viral vector vaccine. So the mRNA vaccines being things like the Pfizer or the Moderna. And both of these really work to try and get a bit of the virus genetic code into a normal cell, which then makes the crucial bit of the COVID virus, which is the spike protein. And the spike protein is just the little bit on the outer bit of the virus, which is how the virus gets into cells and how it starts to cause infection. So if you just give a little bit, if you allow cells to make a little bit of the virus, you can then mount an immune response against the spike protein, and that's how these vaccines have been designed. So obviously none of them are weakened by a whole virus, so they won't cause a coronavirus COVID-19 infection. And very similarly, the Oxford vaccine works in a similar way to just give a bit of the messenger genetic code so that you can make a bit of the spike protein, and again enables you to make an immune response. So they're both, the technology's been around for a couple of decades now, but obviously the COVID vaccines have been the first ones that have been licensed using these sort of newer technologies. So this was our study design. So we had quite a lot of time points, and I'm sure there's a lot of patients on this who have been very kindly taking part. But what we've done is we've tried to collect samples, and that's both serum samples, so that's where we can find antibodies, as well as we've tried to collect some live cells so that we can look at things like T cell responses. And we've been getting those pre-vaccination wherever we can, and then at about 4 to 6 weeks, where we'd expect this sort of peak immune response to happen after each vaccine, We've also added more time points to try and understand how long the vaccine responses work for. So going on to pre and post booster to around 6 months. So I think a lot of people will have had boxes through the post very recently. And then we're also going to ask for another sample in around 6 months' time as well. And using these, so when we get these in the lab, it takes us about 2 hours or so to get them all stored down. We've been freezing down samples so that we can do all the experiments at a later date. We're also sending some of the samples off to various other places to do things like looking at how well the blood can neutralize the virus, and some of that experimental work's being done in London. So all of the patients that had previously consented to be part of our research tissue bank could be eligible to be included in this study. We've got about 600 patients in our service nationally, and about 300 of those had consented to be part of the tissue bank before the pandemic. So that meant that we could ring people up and check they were happy to have the extra samples without any kind of further consent work being needed. Very few people said no to being part of this when we asked. We tended not to ring people though if they only needed a blood test once a year, because we didn't want to ask people to go into hospital for a blood test just for the study, because again that wouldn't fit in with our ethics. We also didn't include patients who were on, who'd had a bone marrow transplant, just because there were other studies available for this and we didn't want it to kind of confuse our results in our patients. And there was a very small number who were on immunosuppressants for other reasons, things like kidney transplants, that we didn't include in the final analysis, just because again, that might affect our results. So this was just to show how many, the sheer volume of samples that we've had coming in. So about 630 samples so far at last count, over 4 time points so far. So we've had plenty of work in the lab, plenty of samples. So this is just, over the next few slides, I'm just going to go through the first experiments that we've been doing. So just to start with, we've been looking at antibody levels, and we've used a kit that measures the various different types of antibody that you can get to the spike protein. And we've used a kit that's called an ELISA to do that. And it comes with, we get lots of different plates, and we can run about 40 samples on a plate. And we have lots of controls to make sure that every experiment we do, there isn't a lot of variation between them, so that the results are quite, they can be quite, you know, when you repeat them, they're fairly good. And we have shown that when we do one patient on one day and one on another day, we do tend to get very similar results. So this was just, hopefully you can see the top of that slide okay, but just done a little diagrammatic representation of what's actually going on. So we have a plate here, and in each well we've got 1 patient sample, and we've done each patient twice. And at the bottom of each of these little wells, you've got the spike protein there coating the bottom of the well. And then what you do is you put the blood sample in, and if there's antibodies in that sample, it will bind to the spike protein at the bottom. We wash it quite a few times, and then we add in another antibody that then, if there's antibodies in that sample, it will then bind. And then after that, you add in a few more things which allow a colour change if antibodies have been detected. And the strength of that colour change is then proportional to how many antibodies are in that well. So you can probably see here, it's quite a nice blue colour. So the stronger the blue colour here, the more strong the positive result is. And we then put it in a machine. So I'll show you just, hopefully this works. We then put in a little stop solution, so it changes colour, and we stop the reaction. And then on the next slide, it goes into it's called an optical density reader, but the plate goes into this machine here, and it measures how bright that colour changes and gives us an exact reading. And then the manufacturer gives us a cutoff of what's positive and what's negative. So here are some, so this is this is quite a busy slide, but it's just to show the numbers here. So we had 45 healthy volunteers. Most of this was targeted at patients who'd been part of the PNH tissue banks. We've got a lot of patients with PNH, but of course, all of these patients will have at some point likely had aplastic anemia in the past, even if we don't have a history of that in our records. So here we've split these into 3 groups. So classical PNH is the ones that we've called those where they don't have a history in their notes or on their bone marrow of having aplastic anemia. They've just presented to us with PNH at the beginning. In the middle group, we've got patients with what we've called aplastic anemia and PNH overlap. And that's those people who have got PNH that's enough that we're doing something about it. So they're on a complement inhibitor, or we've had to give warfarin because the clone is quite a big size. And these patients also have got a definite history of aplastic anemia, either on a bone marrow or on blood tests that we've done, and we've needed to treat it. And then the final group is we've called the aplastic anemia group. And these are people who have got their main problem is aplastic anemia. Patients may have a PNH clone, but it's usually less than an arbitrary value of 50%. So it could be anywhere from sort of 0.1 up to 50, but is not causing any symptoms or needing us to treat it. So we've got about 172 patients. These are just the ones that we've analysed so far on the initial test that we've done. We'll have more to add later, but so far 170 patient samples. On the next line here, just to highlight, there were some slight differences in the ages. So our healthy volunteers were very slightly younger than all of our patient groups, which may have a slight impact on how well we can compare the results, but shouldn't have a huge impact. We had slightly more female healthy volunteers, which we wouldn't expect to have any difference on the results. It's important, obviously, that we try to standardize how many days we took it after the vaccine, because if it's months and months, the antibody levels might go down too low, but this was all the same in all of our groups after vaccine 1. It was a bit longer in our aplastic anemia group after the second vaccine, but it's only marginal. It's about 20 days. And I think that was because it was quite difficult if people aren't having regular blood tests to get samples. Our patients who are on treatment for PNH are usually having a blood test or having a cannula in every 2 weeks or so. So it was quite easy to get samples. I just wanted to go through a little bit. So between 80 and 90% of our patients in both the classical PNH group and the overlap group were on a complement inhibitor. And then in terms of the ones, so in the people who were in the overlap group and people who were in the aplastic anemia group, about 60 to 70% had previously had ATG. So quite a significant proportion had had ATG in the past. However, I just wanted to highlight that all of these patients had had ATG more than 12 months ago. So obviously we would have quite liked to have had people who'd had ATG more recently, but I think because of the pandemic, we perhaps put off people having ATG for a little bit at the beginning. We're not doing that anymore, but that might be why we perhaps don't have as many who'd had it more recently. We had a very small number who'd had Campath in the past, just 1 or 2. And then between 80 and 90% had had either cyclosporin or tacrolimus in the past, and about 40 to 50% in the aplastic anemia overlap and the aplastic anemia groups were currently on cyclosporin or tacrolimus, and that was quite an important question for us to look at, though, whether those who were currently taking cyclosporin or tacrolimus might have not as good a response potentially. In terms of the brands, about 2/3 of all of our patient groups had the Oxford vaccine, compared to about 1/3 having the Pfizer. And I'll just go through to the next one. So this is our main slide of results. So I'll talk through these because I know there's a lot of information on this slide. So this is our, basically we've got 2 graphs here. The top one is what's happened after vaccine 1, and the bottom graphs are after vaccine 2. So the ELISA result here is basically how bright that colour change was when we looked at the ELISA, and anything above a certain threshold is considered positive. The brand of kit that we used doesn't let us actually quote a specific number, but it just says it's positive or negative. But where we plot the result does give you a sense of how positive things were. Each of these dots are an average of 2 results. And here we've got in blue, we've got the healthy volunteers. In green, we've got patients with classical PNH. In purple are the overlap group, and then in pink, the sort of more pure aplastic anemia group. And after vaccine 1, there was significantly reduced levels of the antibody results in all 3 patient groups compared with our healthy volunteers. And that was mathematically significant. So it was about sort of 50 to 60% of all of our patients were having a positive result compared with 95% of our healthy volunteers. However, when you look at the bottom graphs, this is the much more reassuring graph. After the second vaccine, there was no difference seen between our healthy volunteers and any of our patient groups. So this bar chart here on the right-hand side just shows that nearing 100% of all of our patients and the healthy volunteers had a positive antibody result. And there was no difference in the level of the antibody result either, which was quite reassuring, really, from these initial results that we've seen. Obviously, this isn't the sort of full story, and we need to look at the T-cell responses and other bits, but just in terms of a pure antibody result, that was very reassuring to see. So we wanted to just try and work out, who are these people that are not making it above the line, and we've tried to kind of subdivide it a little bit more. So I'll go through that over the next few slides. So we had a look at patients who were currently on either cyclosporin or tacrolimus versus those who weren't. The ones that are currently on treatment are the ones here in red, and the ones that were not on treatment are the ones in blue. And you could argue maybe there's a hint of a lower response, but statistically there was no difference seen after vaccine 1 or after vaccine 2. So being on either cyclosporin or tacrolimus made no difference to whether you responded or not to the vaccine. Sorry, I've got some more graphs here, but just these ones are showing the lines are connecting individual patients. So where we've got data points for individuals, you can plot to see what happens to their antibody response after vaccine 1 and after vaccine 2. So you can see in our healthy volunteers, they do go up a little bit, but really in all of the 3 patient groups here in green for the PNH, overlap here in purple, and the aplastic anemia group in pink, all of them go up almost 3 times after the second vaccine compared with the first, just showing a really good improvement after that second booster. We wanted to try and understand if there was an impact of age on our results to see, is it older people that are not doing as well? But actually, we did see that a trend to older people not doing quite as well in terms of the antibody level in our healthy volunteers. But there was no pattern in any of the patient groups. So, we had some young patients who didn't have particularly high levels, but we had some older patients in all of our patient groups who had fantastic, really strong positive antibody results. So that didn't seem to have any impact. And that was the same pattern after vaccine 1, and the same happened again after the second vaccine as well. So finally, we wanted to have a look at, we've got a huge cohort of patients who have had the meningitis vaccines, and we have some patients that just never respond to the vaccine, and we have to keep giving boosters, and sometimes we even give up giving boosters. But actually, when we went through all of that data, so here on the top 2 plots, sorry, I'm afraid it's lots and lots of dot plots, but we compared those who have had a history of needing a booster because they didn't have a good enough response compared with those who've not needed a booster. And there was a slight difference after vaccine 1. So those who have a history of needing a booster for meningitis had a slightly lower response after vaccine 1, but as you can see, it's very minimal. And after the second vaccine, there was no difference found. So that was very reassuring because it suggests that those, even those who have not responded very well to the meningitis vaccine can still respond well to the COVID vaccine. And then on the bottom 2 plots here, where I've put NR, We looked at those with a history of having non-response to the meningitis vaccine. So these are people who have, have mounted the worst responses. And again, even those with a history of not responding to meningitis still had a very good response to the COVID vaccine, which was very reassuring. We've had a quick look at the brands. Is one vaccine better than the other? And actually not really found any particular difference so far. So here we've got at the top, I've got my, so these are all our patient results in the top two plots, and then we've got our healthy volunteers in the bottom two plots. On the left is post-vaccine 1, and on the right post-second vaccine. So there was no difference after the first vaccine. After vaccine 2, there was perhaps an increased level with the Pfizer vaccine, seen in both our patients and our healthy volunteers, but this generally does seem to have been seen in the literature. Whether it's clinically different, because I mean they're all still positive, maybe there's a slightly higher antibody level in the Pfizer, but it's not sure how clinically significant that difference is. Whether that means you're more protected, it's not clear yet, and we'll know that in the fullness of time. So just to touch upon finally, what COVID-19 infections have we actually had in our cohort of patients? So we've got over 600 patients in our service nationally. We obviously rely a lot on patients ringing us, but 49 patients have rung us to say that they've had a positive PCR test, and we've been trying to keep a record of how bad their infections were and what symptoms they've been having. So before the vaccination program last year, we did have five deaths in our service, and one patient who needed intensive care admission but subsequently recovered, and these were all before vaccination. We've not had any deaths so far this year since the vaccination program has started, which is also very reassuring and I think mirrors the sort of data that we've been seeing so far. Just when we've gone back specifically to look at, we don't have data for all of those 49 patients because they weren't all in our study, but we did have them for 14 patients. So 14 of the patients who had COVID infection after the second vaccine, we went and had a look back to see what their antibody levels were. And it was interesting that in all of them, after their first vaccine, they'd actually had fairly poor response to vaccine 1. But after the second vaccine, there was quite a range of responses. So it may be that we just need a booster to get people up to a level which protects them. But obviously that's something that we'll start to kind of tease out over the next few months. In terms of side effects, so I know that's been a lot of questions that have been coming through about side effects. Are we seeing worse side effects in our patients? And that hasn't been the case, which again is quite reassuring. So we've had, again, we're reliant on people ringing us to tell us how their vaccine went. And so far we've got information on about 370 patients who have either rung us or we found out in clinic what side effects they've had. And we've been recording that in a sort of huge spreadsheet. And generally, the vast majority of symptoms have just been the same as other people in the community, really. So sore arm, maybe a fever or feeling a bit achy. In terms of the sort of more serious side effects that you worry about with PNH and aplastic anemia, we've had 4 cases of breakthrough hemolysis, and 2 of those were admitted to hospital, but all recovered, and all were managed with either just an increased dose of their complement inhibitor or an extra dose. I know that so aplastic anemia relapse is obviously a worry in with other vaccines as well. There's obviously a small risk with any vaccine, but we haven't seen any significant numbers of aplastic anemia relapse. So we had one patient in whom their first presentation of aplastic anemia may have been related to the vaccine, but we obviously can't prove that. And we've had a small number of people who have had slight drops in their counts, generally a small drop in platelet count, usually only sort of 20 to 30, something like that. And that's recovered without any intervention in all of the cases that that's happened in. Just to mention at the bottom, there is another study, because I know this was one of the questions that came through earlier, but there's a working party group. So the Severe Aplastic Anemia Working Party, which is part of the European Blood and Bone Marrow Transplant Service, is doing a Europe-wide study to look at the long-term effects in terms of clinical outcomes on the from the COVID vaccines. So particularly looking to see if there's any increased rates of relapse. Again, they would have told us if there'd been any significant numbers of this happening, but that will hopefully report in the next few months. I think they've collected follow-up data from about 500 patients Europe-wide. So just this is the highlight really at the bottom, just to say that nearing 100% in all of our patient groups had a positive antibody result after the second vaccine, which was very similar to the healthy volunteers. And then our plan going forward is, so we've obviously sent, I'm sure a lot of people will have boxes for blood samples post-booster, which is ongoing at the moment. We're going to run all of the samples we're going to be doing, looking at exact antibody levels, so slightly different ELISA kit. And we're also going to be looking at the other important part of the immune system, which is the T-cell immune response. And that'll take us a few months, likely after the Christmas period, to do. But that's a really important part of the immune response to look at. We're also sending samples to London to look at how well the blood samples neutralize the COVID virus, which is another very good way of assessing how good the antibody response is. And obviously, we're very grateful to the AAT for their ongoing funding and support of this study. So obviously, this wouldn't be possible without the rest of the clinical team and the lab group that we've got working very hard here. And of course, a huge thanks to all the patients who have taken part. I think that's it. So any questions really? I'll just...
Thanks, Alex. Maybe I'll just summarise, from my perspective, and I think we're very reassured by the responses we've seen, certainly compared to some of the other patient populations that I look after with leukemia. And I think with everyone responding, I think what we've seen is that you need the 2 vaccines. So the response after 1's not as good as after 2. So it's really important to have the 2. And I suspect, therefore, the booster is really important, will be important, as will be the 3rd or 4th. Our patients can have 4 vaccines. So I think it's really important to keep up with the vaccine rates. And I think the other thing that's really reassuring is that the severity of COVID, even with Delta coming this year, has been far less after vaccination than before. So we have a sort of functional measure of how well it's working, not just antibodies. And so that's very reassuring.
Wonderful. Thank you very much, Alex and Peter, for clarifying that as well. I'm sure I probably saw a collective sigh of relief amongst everybody that's here there, really. You know, we are absolutely thrilled to be seeing these incredibly reassuring results from the study, of course. We have had quite a few questions that have been submitted already, and I think Alex's excellent presentation has probably covered most of the content there, but it is absolutely still worth us covering the questions. So I'd like to start off first with a question from Ruth. Ruth has said, I've had my 3rd primary dose of the COVID vaccination. Will this actually help, or will my compromised immune system be a barrier to me having adequate protection?
I think I think it sort of depends really on kind of exact underlying disease and what treatment they're on. But generally, obviously our results, I can only generalize to people who have had ATG more than 12 months ago. So it might depend a little bit, you know, have they had a transplant or, you know, or on any other treatment. But generally, at the moment, we know the vaccine responses after vaccine 2. So we're still working on the post-booster. So we won't know probably for a few months what the post-booster results look like and what the T-cell results look like. So we would still just say, yes, do have the jab and go around being sort of sensible. Obviously, we're not saying to people to wrap themselves up in cotton wool and stay at home and not go out, but at the same time, you know, generally doing things that reduce your risk, like perhaps not going to big nightclubs and things like that so much, because we don't fully yet know how well that antibody response is going to work.
And just to add to that, we do have some, obviously our patients have had the third vaccine, many of them, and we're collecting samples on them, and we haven't seen any particular side effects with the third vaccine either. So I think we're very comfortable that these vaccines are safe for our patients, first of all, and clearly not being vaccinated is not safe. So really, you need to keep up with the vaccines as they're offered to you to be protected. But to everybody, even ourselves, we have to risk assess every situation. So you don't want to go into very crowded space, especially with Christmas coming. You know, lateral flow tests and the like, just to make sure that your family aren't carrying it when you see them, and are really important, I think.
Thank you very much. The next question that we have is from Ingrid. Ingrid, I believe, is a patient with PNH. She said, are any of the vaccines safe for people with PNH? And if so, is there a preference to which vaccine that I should receive?
I think, as Pete was saying, we're quite confident now that the vaccines are safe in our patients, having collected now over 360 patient responses nationally and not seeing any significant numbers of side effects compared with healthy volunteers. In terms of which brand, we're not really recommending a specific brand at the moment, just because we don't have the full comparison in terms of T-cell responses as well. And obviously, you know, for the third primary, there's only, I think, 2 choices anyway. So I would just go with what you get offered.
Fantastic.
The only thing I'd add to that, Sam, is that our PNH patients are almost all on complement inhibitors, and so for patients, there are a small number of PNH patients who aren't on Soliris or Ultomiris, one of the other complement inhibitors, and we haven't studied many of those patients. So there is a possibility that it would cause a breakthrough in those patients, but undoubtedly, in my opinion, the risk of not being vaccinated is higher than the risk of being vaccinated. But if a patient has a vaccine and then gets a reaction, then they need to let us or the local doctors know so we can deal with that. But we haven't seen it as an issue. That's fair.
Excellent. Thank you very much, Peter. The next question that we have is from Emma. Emma has asked, given that the Pfizer third primary dose works by getting the body to produce certain blood cells, is there any risk to this throwing the bone marrow off from its normal job and triggering a relapse?
Yeah, so I mean, we know that some vaccines can potentially trigger a relapse, like we've seen the odd case report after the flu jab in some patients with aplastic anemia, but it's something we've been very vigilant for and not seen. Again, it's something that the aplastic anemia working group around Europe are collecting data on, but so far we've not seen enough of a signal to say people shouldn't get the vaccine.
And just to add to that, I mean, the anecdote, what we would consider as doctors as an anecdote, what's called anecdote. So there'll be odd descriptions of people reacting to vaccines or vaccine causing aplastic anemia. But we've vaccinated lots of patients in the past against meningitis, against other things, and we haven't seen a relapse of the aplastic anemia in that situation. Just as what's interesting, I think one of the interesting things about this study is that the low response to the first one and the high better one to the second one, because the immune response is different between the first and the second time you see a virus, and this is what we're seeing. So actually the third one is another second one. It's more like a secondary immune response. So there's no reason that a third one would be any different to the second one in terms of side effects, and is likely to increase the response even better. So the more times we see a vaccine or the more times we see a virus, the higher the response we get, that usually lasts for longer. So there's no concern about the third vaccine if you've had the 2 and been okay, and I think there'll be a 4th one coming, which is important as well. So keeping up to date is very important.
Excellent, thank you very much. The next question that we have is from Karen. Karen has said that she has been in remission for several years and has received both doses of the AstraZeneca vaccine. I had absolutely no side effects after these, not even a sore arm. Does this mean that my body is not responding, or have I just been lucky not to have any side effects?
I think you've just been lucky. Well, a lot of our healthy volunteers have had no side effects at all, and you can still see a very good antibody response. So it just seems to be a little bit luck of the draw. There's no data to really say how bad your immune system responses might indicate how well you respond to the vaccine. So yeah, I think just lucky at the moment as far as we know.
Yeah, and switching to a different one as the third vaccine is probably quite a good idea, actually, just from all the other vaccine data we have. So going to Pfizer and Moderna, which people will get as the third one, is a good idea. First of all, we see a slightly higher response in the, although it's not really, we can't really say that scientifically, but we do see a slightly higher response in the data, the work that Alice has done. But switching to the Pfizer or Moderna is a good idea.
Excellent, thank you very much. The next question that we have is from Diane, and Diane has asked, do we yet know whether the current vaccines will be effective against the new Omicron variant?
Unfortunately, we don't know yet. We know, I mean, that's something that will come out as we send all these samples off to London for these neutralization assays that we do. So we know that in other studies, some of the other variants like the Delta variant, they haven't neutralized as well in kind of all patients and healthy volunteers. So it may well be that they don't work as well, but we don't have that data yet. It's something we hope to get over the next few months.
Excellent, thank you. The next question that we have is from Daniel. Daniel has asked, how do we know that the vaccines are safe when we've never used mRNA technology before, as we have no medium to long-term data?
I don't know if you want to do that one.
Yeah, I mean, this is one of the things which interests me really, because these vaccines have been given to literally hundreds of millions of people globally over the last 12 months, and we really haven't seen any significant side effects. We know that more than other vaccines, in fact less than other vaccines probably. And so the sort of story that these vaccines haven't been tested is completely wrong, because we've given them to so many people. I mean, you know, we know exactly what the risks are of these vaccines. Once the vaccine, we're very unlikely, there's no really rational reason. I don't want to get into the anti-vaccine type discussion because we can go back a long way with that, but there's no rational reason why it would be different in a year's time or 2 years' time, you know, than it would be soon after the vaccine. So most of the vaccine reactions that are genuine vaccine reactions will happen fairly soon after the vaccine. And so I'm very comfortable that we know what the risks are and that they're small. Yeah, so I think that's fair.
That's wonderful. Thank you very much, Peter and Alex. The next question that we have is from William, and William has said, there have been many treatments for aplastic anemia over the years, such as oxymethylone and ALG, rather than the currently used horse ATG and stem cell transplantation, for example. Does your research include any data regarding the outcomes for patients who've received these treatments that are not necessarily used nowadays?
Well, we still use some of them in patients who haven't responded well to ATG and cyclosporin if transplant isn't an option for them. So, but we would obviously, there'd be small numbers of patients in this study. So Alex will have probably collected some of the data. That Campath is rarely used, but we've used it more in Leeds, I guess. Alex, I mean, you know about the androgens.
Yeah, so in terms to the androgens, things like oxymethylone, danazol, we have got plenty of patients who are on that. We haven't subdivided it because we didn't consider them to be immune suppressive as such, because they're more sort of stimulant acting. And similarly, we've got obviously a large number of patients on L-Trombopag, but we wouldn't expect that that would reduce your immune response. So at some point we could certainly go through and subdivide what people are on, oxymethylone, L-Trombopag and things, and see if there's any difference, but we haven't done that to start with because we weren't expecting there to be. And for the transplant ones, I haven't included the patients who've had transplants in the analysis just because there were different studies, something called, I think Octave was one of the studies, and they've included patients who are post-transplant, and that's a different effect on the immune response, really.
Excellent, thank you very much. The next question that I have is from Paul, and Paul has asked, again, potentially not included in this study, of course, but is there any data available regarding the efficacy of vaccines for children at the moment?
No, not in this study, so I haven't included patients with children because again, they're not part of our service, so we don't in PNH and aplastic anemia for ours. I'm not aware of any big studies looking at the vaccine responses in children in this disease.
I mean, maybe Louise could comment, because Louise collected a lot of the data on our meningitis vaccine, so we have a huge amount of data over many years in meningitis, and I think one of the really intriguing observations is that even those patients who don't respond to repeated attempts to get meningitis response respond to these COVID antibodies. So that's to me a bit surprising, but really encouraging as well. I mean, Louise has got a lot more information. She collected all that data, but I can't see her in front of me. So she's disappeared. So
she's in the waiting room.
Yeah, that was very reassuring. I think that we see even people with poor responses respond. There's no reason why children wouldn't respond, and I think from a safety perspective, I mean, obviously that the advice is changing to allow children to have the vaccine, so that they're considered to be safe in children. So I think for our patients, they equally need to be protected against COVID. So I have no concerns.
Excellent, that's wonderful. I'll just go to some questions that we've received in the chat before I continue on the ones on my list. We've got a question from Mandy. Mandy has said, I know it's early days, but do you think going forwards there will be a yearly jab like the flu one as we do for COVID, as generally the COVID virus won't be going away anytime soon?
Maybe I'll have a go at that.
Yeah, go for it.
So I think it really depends on what happens with this virus. If the virus becomes less potent, which sometimes can happen, or if the medication that's coming through, which I'm very optimistic about, but I'm an optimist, works effectively for COVID, then that will improve things. But I think for the time being, I think we have to assume there will be boosters coming through. Whether they're going to be specific to variants or whether they'll be more of the same is not clear at the moment. And we'll keep collecting the data as patients have boosters.
Excellent, thank you very much. We also have a question from Daisy in the chat as well. Daisy's asked if there is any data out there for people that are currently on a watch and wait pathway, so potentially people with non-severe aplastic anemia or just a very small PNH clone.
Yeah, so quite a few patients were included. So I think I had about 40% that were currently on treatment. So that's still a significant proportion that aren't actively on treatment that were included in both the aplastic anemia PNH overlap group and the aplastic anemia group. So yes, plenty in there who are in a remission. When we finally go through the analysis, we will try and kind of divide it into people who, depending on their counts and things like their lymphocyte counts and kind of when they're in it, whether they're in a complete remission or a partial remission, that sort of thing. But yes, we have included those.
Excellent, thank you very much. I can also see that Shreyans has his hand up as well. Shreyans, would you like to add anything?
Firstly, Alex, thank you. That was very clear and a very excellent presentation. I have to congratulate Prof. Hillman and his team and yourself. Brilliant study, very clear study, much needed. And I just have to, absolutely congratulate you on this fantastic piece of work. I think I had a slight technical question and it's kind of almost answered, but I thought I'll just bring it up anyways. Classical PNH patients, when their serum samples were collected, would probably have some anti-complement eculizumab or avelumab in these samples. And assuming the test that we've used is the indirect agglutination test in testing antibodies, was there any false positive testing when you tested these samples at baseline?
I don't think we've had it. So I suppose the antibody should just bind to the spike protein on the ELISA plate. But all of our kind of controls worked fine. We haven't specifically looked at different time points as to when they had their eculizumab. I don't know if Pete's got any other ideas.
Well, most of them will have been trough levels, but they still would have had antibody there. And I think if they had been a systematic issue, we would have had it would have been very positive in every patient. So a negative control plate should have come up as well. So I think we probably have excluded that's an issue for the ones on anti-complement therapy. Although we could probably design more tests to look at it.
Yeah. But yes, I suppose because they've all been taken at the time that they're due the eculizumab, it's done as the cannula goes in. So yeah, it's going to be the best trough sample that we can get.
And some of them are on other complement inhibitors as well, so not necessarily antibodies. Some of them are on trial drugs and other things which aren't antibodies, which obviously wouldn't interact.
Excellent. Once again, fantastic piece of work, and I cannot congratulate you wholeheartedly. This is much needed and brilliant piece of work. Thank you so much.
Thanks, James.
Excellent. Thank you very much, Ryan. We've also received another question from Pauline in the chat as well. And of course, we know that post-transplant patients weren't included in this particular study, but she has asked, would you expect to see a very different response from somebody who's received a stem cell transplant?
I think we'd expect to see the same, at least as good a response, because we revaccinate people post bone marrow transplants, stem cell transplants anyway, and see responses. So I would anticipate a similar response, or equally good. I wasn't going to say better, but I don't think you can get much better than we've seen. So
fantastic. That's lovely. The next question that I've got is, and I'll just go to my other page. This is more of a general question, really. And I hope that the person that sent this question in has been very reassured by the data that we've seen. But they've asked, in general, what precautions should the family members of somebody with aplastic anemia be taking day to day to keep them safe?
I think it's just general advice. So again, encouraging all your family members to get vaccinated, just so that you've got a bubble around you of protection, like with the flu jabs, and just being sensible, really. I don't think we're really telling people to not go about their lives as normal, but it's trying to minimize and be sensible and kind of weigh the risk benefit of things.
I think we're all at risk of COVID. I mean, regardless of whether they have aplastic anemia PNH or not. And so it's assessing risk. And I think particularly with Christmas coming, because everyone wants to be with the family at Christmas, and that's important. So we'll certainly be, even though we don't have anybody in our family with aplastic anemia or PNH, we'll be lateral flow testing before we travel, because we really don't want to be spreading virus around, and so they're freely available and should be used, I think. So regular lateral flow tests is a good thing to do, and then at least you're protecting everyone in the family.
Excellent. Thank you very much. The next question I'd like to ask, and I'll just find it. Yes, we've got it. This is a question from Gavin, who submitted this earlier. Gavin has said that he's currently 3 years post stem cell transplant. He's had in the past, he's had the pneumonia vaccine, and an antibody test showed that he had absolutely no response to the pneumococcal vaccine. Given his history of having no response to the vaccine, is it likely that his COVID vaccination will have been successful?
Again, I mean, we don't obviously have that data in our study, so I wouldn't be able to extrapolate it. I mean, it was reassuring that even the ones who'd had poor responses in our study still might respond to the COVID vaccine. So it's quite difficult to compare one vaccine with the other, because they're all different technologies and work in different ways. But these ones seem to be, the COVID vaccines that we've seen so far seem to be quite effective. So I don't know if necessarily not responding to the pneumococcal would mean he wouldn't respond to the COVID vaccine, but can't really extrapolate our data to cover his situation at the moment.
So you can say that just because he hasn't previously responded to a different vaccine, you can't assume that he shouldn't have COVID, because the COVID vaccines are, the pneumococcal vaccines are probably more similar to the meningitis vaccine than they are to the COVID vaccines, actually. And so it's likely that he possibly would respond. You can test response clinically as well, of course, if the transplant team there want to know if they've responded. So it's worth thinking. Louisa's returned now. So.
Excellent, lovely. We've also had a question from Pauline in the chat as well. Pauline has said, what would you consider a good response to the vaccine to look like, as the results seem to cover a fairly wide range from what we saw?
Yeah, that's the really good question, and one that, again, we hope to answer, but we don't have an answer for at the moment. So the tests that we do are really just validated to be positive or negative. And whilst, yes, we can see a range, and it probably does correlate with how good the test is technically not valid to make that assumption. So what we're going to do next is the antibody test, where you get a specific level, and that's using a kit that's kind of internationally calibrated with a standard from the World Health Organization. So then what we're hoping is that the data will start to come out and will give a specific level that we can then use as a mark-off to say, yes, this will protect you. But the problem is that even just having an antibody level that's protective might not necessarily be the full picture, because we need a good T-cell response to be able to protect from COVID infection as well. So at the moment, it's a very difficult question to answer. I know we'd really like to have a number and say, yes, you're going to be fine, but we just don't have that at the moment.
I mean, it is semi-quantitative, what we would call semi-quantitative. We get an assessment of the level, but we can't measure it in the way that we want for quantitation. As you saw from the graphs that Alex showed, the levels are very similar to normal individuals without aplastic anemia. So that's reassuring that the levels of response after 2 vaccines are equivalent to a person without aplastic anemia PNH having a response. But probably more reassuring still are the cases of COVID and how severe they are. And you know, I've managed a type of leukemia where we've seen no reduction in the severity of infection this year compared to last year, and we don't see responses. Whereas in our patients, we're seeing less. You know, we're not seeing the severe infections. It doesn't mean anyone can end up very ill with COVID. So it doesn't mean you should go out and get it and take any risks. But it is very reassuring that we're seeing, you know, the levels. I'll show you just our levels of a test, but they are consistent with what we're seeing in terms of protection in the real world.
Excellent, thank you very much. There's also another question that I've got, and it is one that we receive an awful lot at the AAT, and it's more of a practical question. Is there any way that a person with aplastic anemia or PNH can routinely get access to an antibody test on the NHS?
I think it depends which trust you're in a little bit. So I don't think they are routinely available. I know that sometimes in our trust we can do the odd test, but it usually needs to go through the immunologists. So I think that very much varies.
I guess to some extent also, what for an individual patient does it make a difference? Because you know that most patients respond, and what we as you probably know, we have antibodies against COVID now, which are treatment antibodies rather than the antibodies we have. And patients who don't have antibodies from the vaccine and catch COVID can have, it's called Ronapreve, is the one that's approved. And so if a patient was unfortunate to contract COVID, then it's worth knowing about the antibody levels, because you can actually do something about it. And that drug is funded on the NHS for people who are in the early stages of the infection. And so I think you may be able to, as I said, you might be able to get your local team to request a COVID antibody, but it's really important if someone is exposed to COVID to know at that point, because it could be that you have an antibody now, but in 6 months' time you don't. And so, you know, so that's why we're doing a 6-monthly and a 12-monthly, you know, the follow-up of the antibody levels. And so, so maybe is the answer, but I wouldn't be chasing it if I was a patient. I would be waiting and having my vaccinations.
Of course, thank you. Mandy's also posted in the chat as well. She's asked if we could just clarify the answer to the question about responses for people on a watch and wait pathway. She said, could you clarify your answer to Daisy's question, as it was watch and wait? Did it mean for people that have had no current or past treatment, patients, not ones in remission? Yeah, just trying to read that again. Yeah.
There were a small number that had never had a cyclosporin or tacrolimus and weren't currently on it. So yes, I can't tell you the exact number offhand, but a small proportion were just on a watch and wait and had never had treatment.
And we wouldn't expect them. Their immune systems should be normal at least. I mean, compared to what we're worried about with cyclosporin and tacrolimus and ATG is whether they've actually suppressed the immunity. And so patients who haven't needed that treatment, you'd expect them to respond. And as Alex said, our data would support that.
We obviously won't have a huge number in the study, just because they won't have needed to have blood tests every few months. We haven't taken, we've only really included people who are going routinely for bloods.
Excellent. And just to wrap up as well, I have one final question, and I think we probably all know what the answer to this one is. What would you say to those who have questions about the need, the safety, or the relevance of vaccines during the pandemic?
Repeat.
Yeah, I mean, a risk of becoming political and potentially angry. In the general population, the mortality from this virus has reduced by about tenfold because of vaccinations, and that's when we've got a nastier variant of the vaccine around. And when I look at my leukemia patients I mentioned before, it really upsets me that a large proportion or even a small proportion of the population aren't being vaccinated, and they're putting those individuals at risk. And so, we can talk about science, and we're scientists and we understand the immune system, but there's no rationale for the sort of vaccine hesitancy in this situation, and actually it's dangerous to our patients. And so it's not like a choice that you're making for yourself, it's a choice you're making for other people who are vulnerable. Maybe Louise, we managed to not get you to I asked you a question when you were away, but
I'm so sorry, I've had a really bad internet the whole way through, so
okay.
I missed a lot of it, so I apologise.
Yeah, so that would be my view, but I don't know if Alex and Louise have a view on vaccine hesitancy in our patients or generally, without getting into trouble.
I think my only comment will be the 5 fatalities we saw before vaccinations, and all of those have taken us down as nurses and as a team, and anyone that's hesitant just needs to think of that, really. But yeah, I agree with what Pete says. It affects everybody across the board, doesn't it?
Yeah, I would agree. So the fact that there's been no further deaths or ITU admissions since the vaccine programme is just really probably speaks more volumes even than the numbers that we're presenting today.
But I would like to add as well that I do understand the hesitancy around it, and that's where my role comes into it, and happy to talk to anyone and support people through that. And we have done that quite a lot over the last year or so, and spent a lot of time sort of going through things and hesitancy and anxiety around it. And that makes sense, because I can understand that if you have bone marrow failure or aplastic anemia and not wanting to upset that balance. So, there is support from the team here and King's.
There was a question in the chat actually about the flu vaccine and whether that changes our advice on the flu vaccine. I think it's a bit difficult because we haven't really studied the flu vaccine. As I said before, the issue for aplastic anemia and vaccinations has been rather occasional patients that have we've had associated bone marrow problems after a vaccine. In this particular situation, where the virus is so dangerous that we've therefore gone through a vaccine program and it looks very safe. So I think we need to reappraise that advice personally, but we don't want to do it on a webinar. We want to do it as a group and give advice across the aplastic anemia community. So I'm not concerned about vaccinations that as much as others, but that's always been my position, I have to say, when we've discussed it. So we probably need to look at the advice again.
That's wonderful. Thank you very much for your responses to that. We are out of time now, I'm afraid, but we've certainly covered an incredible array of questions there, and it's been an absolute pleasure to see your data, Professor Hillman, and to the team as well. Thank you so much for the work that you've been doing. On behalf of the community, I can see lots of applause going on at the moment, and we congratulate you on your success with the research. So thank you very much.
Thank you.
Thanks for having us.
Excellent. So thank you everybody for joining us this evening. It's been an absolute pleasure to have you with us. We will of course have recorded this webinar, and we will be sharing that on the website very shortly, getting lots of the information about research up on the website. So if you need anything from us, please do get in touch or look at the website. Have a great evening, everyone.